For over 50 years, the NHS treatment for COPD has followed the same pathway. Inhalers, better inhalers, stronger inhalers, but still inhalers. On the 26th of March 2026, that changed. NICE approved the very first biologic injection for COPD on the NHS. And here is what you actually need to know. Patients in the United States have had access to this treatment for more than a year. Thousands of UK patients who qualify for it right now have never been told it exists. Something even more important you need to understand right now, this treatment does not work for every COPD patient. There is one specific number in your blood test that decides whether you qualify, and most patients have never had it checked. Your GP may not even know this exists yet. So if you have COPD and you are still struggling despite your inhaler, stay with me, because what I am about to tell you could genuinely change your treatment plan. Here is what you actually need to know about the new COPD injection on the NHS. Hello, I am Dr. Suman Paul, NHS consultant respiratory physician in the UK with my private practice in Manchester and Liverpool. In over 15 years of assessing COPD patients, what I'm about to show you is something most doctors simply don't have time to explain clearly enough. Quick note, this video is education only, not personal medical advice. If you are struggling to breathe at rest, see your doctor or call 999 immediately. Let's start with what makes this moment so significant. COPD, chronic obstructive pulmonary disease, is one of the most serious and common lung conditions in the UK. Around 1.2 million people are formally diagnosed. Millions more are living with it undiagnosed. For decades, the treatment approach has followed the same pathway: inhalers, bronchodilators, steroids, combination therapies. And for many patients, those inhalers work really well. But there is a group of patients, and this is critical, for whom even maximum inhaler therapy is not enough. They follow every instruction, they take every medication, and they still have flare-ups, still find their breathing gets worse year on year. And it's not what most people think. Most people assume all COPD is the same disease, driven by the same process. It isn't. For a significant subset of patients, the problem isn't the inhaler. It's that inhalers cannot reach the root of the inflammatory process driving their disease. Think of it like a fire burning inside the walls of a building. You can spray water at the smoke and it helps, but the fire itself keeps going. That is tied to inflammation in COPD. Biologics have already transformed the treatment of severe asthma, eczema, and other conditions like rheumatoid arthritis. They are precision medicines designed to block the specific biologic signals that cause inflammation at the source. Therefore, for the first time ever, that same precision is now available for COPD on the NHS. But here is the game-changing part most people miss. This isn't just a new drug. This is a completely new class of treatment entering COPD medicine for the very first time in its history. What happened on the 26th of March 2026 is not incremental. It is a category shift. But here is the question that matters most to you. Do you actually qualify? Because this injection doesn't work for everyone with COPD. There is one specific number sitting in your blood results right now, a number most patients have never had explained to them. That determines everything. I am going to tell you exactly what it is. So what exactly is this injection? A drug called Dupilumab, brand name Dupixent, made by Sanofi and Regeneron, the same companies who developed the biologic already used on the NHS for severe asthma and eczema. Here is what actually happens inside your body when you receive it. Your immune system produces chemical signals called interleukin 4 and interleukin 13. Think of this as alarm bells. In certain COPD patients, those alarm bells won't switch off. They keep triggering inflammation in your airways even when there is no active infection present. The airways stay inflamed, the flare-ups keep coming. Dupilumab blocks both of those alarm signals simultaneously. It doesn't just suppress the inflammation after it starts, it interrupts the process that causes it. It is given as a subcutaneous injection just under the skin like insulin. You administer it yourself at home once every 2 weeks using a pre-filled pen device. After initial training from a nurse or a pharmacist, most patients manage it completely independently. It is not chemotherapy, it is not a steroid, it is a targeted biological medicine. In my clinic, I see this every single week. Patients who have been on triple inhaler therapy for years still ending up in hospitals, still deteriorating, told there is nothing more that can be done. But when we check their blood, the marker that Dupilumab targets is sitting exactly where it needs to be. The treatment was always there. The pathway to access, it wasn't. Therefore, knowing whether you have that marker is no longer optional information. It is essential. And here is what you need to understand about that marker. It appears in a blood test most of you have already had. It is measured every time you have a routine blood count. But unless someone knows to look for it and knows exactly what to do with the result, it gets completely ignored. I will show you the specific number to ask for right now. Now, who actually qualifies? 3 factors. All 3 must apply. Factor 1, uncontrolled COPD despite optimal inhaled therapy. This means you are already on maximum inhaled treatment, what we call triple inhaler. Examples being Trimpo, Trixio, Trelegy, a second long-acting bronchodilator from a different class, and an inhaled corticosteroid. All 3 simultaneously. If you are on triple therapy and you are still having significant COPD exacerbations, then you meet the first criteria. Factor 2, raised blood eosinophils. Eosinophils are a type of white blood cell. In some COPD patients, eosinophil level in the blood are elevated. That elevation is the biological fingerprint of type 2 inflammation. It tells us the fire is burning. Here is what you actually need to know. Most patients have never been told their eosinophil count, but it is a simple blood test available through any GP or respiratory clinic. The NICE threshold for Dupilumab eligibility is a count of 300 cells per microliter or 0.3 into 10 to the power 9 per liter or anything above it. Write that number down, ask your doctor for it, bring it to every appointment from this point forward. Factor number 3 is specialist initiation. This is not a prescription your GP can prescribe. Dupilumab for COPD must be started and monitored by a respiratory physician in a secondary care or hospital setting through a formal NHS eligibility process called Blue Tick approval. A consultant reviews your full case, confirms you meet the criteria, often there will be an MDT discussion, and submits the approval request. Only then dose prescribing begin. Therefore, if you are not currently under a respiratory specialist, this is the single most important next step you can take. Now, I know what some of you are thinking. My GP told me I'm on the best treatment available, or I have been told biologics are only for asthma, or I would have to pay privately for this forever. Remember this, because all 3 of those statements are wrong, and I am going to go through them one by one right now. Myth number 1, my GP said there is nothing else they can do for my COPD. Wrong. Your GP manages first-line COPD treatment and they do that well. But Dupilumab is a specialist medicine. It is not within the scope of your GP to initiate this. If you are still symptomatic on full inhaler therapy, there may absolutely be more options. That conversation needs to happen with a hospital respiratory consultant, not instead of your GP, but beyond them. Myth number 2, that injection is for asthma. My doctor told me it doesn't apply to COPD. No, Dupilumab was approved for severe asthma first, that's true, and that's where many doctors' awareness of it stops. But NICE formally approved Dupilumab for COPD with type 2 inflammation in March 2026 under Technology Appraisal TA989 based on the Boreas and Notus trials. It is now licensed NHS funded COPD treatment. If someone tells you otherwise, they have not read the current guidance. Myth 3. I would have to go private permanently to access this injection. Absolutely not. NHS funding is in place for eligible patients. The pathway is specialist review, NHS approval, treatment initiated. A private consultation can accelerate you into that process within days rather than months. But the ongoing treatment, the injection every 2 weeks, can be NHS funded for qualifying patients. The private cost, if you choose that route, is the assessment, not the treatment itself. Let me be specific about what each of you should do next. If you are currently on triple inhaler and you are still having COPD flare-ups or hospital admissions, print your most recent full blood count from GP records or NHS app. Find the line marked eosinophils. If that number is 300 or above, combined with 2 or more flare-ups in the past year, ask your doctor for a referral to respiratory consultant. Use these exact words. I would like a referral for a COPD biologics eligibility assessment. Those words tell your GP precisely what is needed and why. If you are not yet on 3 inhalers and you are still having symptoms, you may not yet be on what NICE called optimal triple therapy. Therefore, the immediate priority is getting your full inhaler regimen reviewed before biologics becomes relevant. Ask your doctor for a structured COPD review or book a specialist consultation to assess whether your current treatment is fully optimized. If you have been told your COPD is stable or well controlled, but you are still breathless, still limiting your activities, still quietly adapting your life around your symptoms, you are not fine. Adapting your life to accommodate COPD symptoms is not the same as your COPD being controlled. You deserve a proper spirometric test and eosinophil count review as a minimum. Those 2 pieces of information could change everything. One practical tip for your booking. When contacting a private respiratory clinic, ask specifically for a COPD biologic eligibility assessment. This tells the specialist exactly what needs to be reviewed. It means your appointment time is used efficiently, and it means you leave with a clear answer and a clear next step either way. Now let me show you why NICE approved this, because the evidence is compelling. Dupilumab for COPD was studied in 2 large international clinical trials, the Boreas trial and Notus trial. Together, they enrolled thousands of patients across multiple countries. Patients exactly like the ones I have just described. On maximum inhaled therapy, raised eosinophil, still having COPD exacerbations. In both trials, Dupilumab reduced moderate to severe COPD exacerbations, hospital admission and serious flare-up by approximately 34%. But it wasn't just the flare-up numbers. Patients also reported significant improvement in breathlessness scores and quality of life measurement, not just statistical endpoint on a spreadsheet. Real meaningful changes in how they felt day to day. Getting upstairs without stopping, walking to the end of the road without fear, getting through winter without an ambulance. And the safety profile, well tolerated. The most common side effect was mild injection site reaction, no increased risk of serious infection, which is often the primary concern with immunological medicines. The evidence is clear, therefore, NICE said yes. And now let me complete the picture, because Dupilumab is not the only biologic story in COPD right now. There's a second biologic, mepolizumab, brand name Nucala, made by GSK, that received MHRA approval in the UK for uncontrolled eosinophilic COPD in December 2025. Mepolizumab works differently. It targets interleukin-5, the signal that directly drives eosinophil production, rather than blocking the inflammatory alarm bells like Dupilumab. It reduces the number of eosinophil being produced in the first place. Think of it as dismantling the factory rather than blocking the output. Mepolizumab is already established on the NHS for severe eosinophilic asthma. The NICE assessment for its use in COPD is now underway. A decision is expected later in 2026. Therefore, if mepolizumab receives NICE approval, UK patients with uncontrolled COPD will have not one but two biologic options, each targeting a different part of the same inflammatory process, each offering a different mechanism a consultant can choose based on your individual profile. We are at the beginning of a genuinely new era in COPD medicine, and I say this as someone who has treated this disease for last 15 years. This has never happened before. Let me tell you about one of my patients. Let's call him Alan. 67 years old, retired engineer, a practical proud man who had managed his COPD for 8 years without complaining, on triple inhalers, doing everything right. But he was still ending up in hospital almost every winter with a serious flare-up. His wife had started sleeping in the spare room because the coughing at night frightened her. He had stopped walking to his local shop not because he didn't want to go, but because the breathlessness halfway up the hill had become too unpredictable to risk the embarrassment. His GP has told him more than once, your COPD is as well controlled as we can make it. When Alan came to my clinic, I pulled up his blood result. His eosinophil count was 410. He meets every single criteria under NICE guidelines. The treatment that was designed for him, proven in trials, approved by NICE, funded by the NHS, is now confirmed. It is coming. And when prescribing opens in the next few months, Alan will not be starting from scratch. He will not be waiting in a queue that hasn't moved yet. He will be assessed, documented, and ready. That is the difference between knowing and not knowing. Here is something most people watching this won't have considered. NICE approval and NHS availability are not the same thing. The approval happened on the 26th of March, but the NHS prescribing infrastructure, the formulary update, the blue text system, the specialist pathways takes time to implement fully. We are looking at approximately 3 to 4 months before consultants can initiate prescriptions around the UK. For most patients, that delay means nothing changes. They won't know about this treatment. They won't have been assessed. And when prescribing opens, they will be referred, then they will be reviewed, adding months to an already long journey. But there is a positive flip side to that window. For patients who act now, who get their eosinophil count checked, who get a specialist assessment, who have the eligibility conversation before prescribing opens, that 2 to 3 months window is not a delay. It's a head start. In the NOTUS trial, eligible COPD patients on Dupilumab experience approximately 34% fewer severe COPD exacerbation in the first year of treatment. That isn't just a statistics, that's peace of mind. And it starts with one simple step: finding out whether you qualify before the door opens, not after. This is exactly what I help patients work through every day at my private clinical practice in Manchester and Liverpool. If you are still having COPD exacerbation on your inhaler and nobody has ever checked your eosinophil count or discussed biologic therapy with you, now is the right time. Not when prescribing opens and every respiratory clinic in the country is overwhelmed with referrals. The link to book a consultation with me is in the description box below. If this gave you clarity, please share this video with someone who has COPD. It might be the most useful thing they see today. Now please check out this video on COPD and home oxygen use. See you on the other side.